Not only that, because RV is failing and try to compensate for the high pressures, it compromises the forward flow towards the left ventricle. And at last, there will be reduced cardiac output, hyperperfusion, systemic hyperperfusion, and the body will decompensate. Let's talk a little bit more deep about that. How RV dysfunction, especially in the acute condition, presents to you in the clinical practice. And I would like to talk more about pulmonary embolism, because I feel that in last few years, especially after the COVID, we are seeing a lot of patients with the acute thromboembolic phenomena, and it's quite a lot disease burden on our society. So these patients usually present with various degree depending how much the clot burden is. They can present with shortness of breath, dyspnea, chest pain, signs of forward failure, syncope, and shock. If you will do simple tests like ECG, you can appreciate sometimes SVQ3, T3 pattern, key onset of right bundle branch block, T wave changes, and if you can do a bedside echo, which is now a blessing in our intensive care and the anesthesia, that most of the physician knows how to do a bedside echo, and they are good to do focus. They can appreciate that there is a sudden dilatation of the right side. There is a characteristic D-shaped septum, which is a pushing the left ventricle. You can see the reduction in TAPSE and the famous McConnell sign. And you can do some point of care simple testing like BNP and troponin, and you can see the rise in their levels. And if you want to see the indicator of systemic hyperperfusion, then lactate can give you a good guide for that. And then you can confirm your findings with CT pulmonary angio. So this is how the acute presentation of RV dysfunction secondary to thromboembolic phenomena looks like. In contrast, the chronic presentation, you can appreciate depending which phase of the disease the patient is. If the patient is in chronic phase, chronic progressive phase, or acute on top of chronic phase, you can appreciate the diversity in their clinical presentation. You can see both the double hit, the backward changes in the backward failure plus the forward failure. So you will see the rise in GVP, peripheral edema, hepatosmegaly, ascites, renal congestion, gut edema, signs and symptoms of gut edema. Plus, you will see the signs of shock because of the forward failure. That's also, you can appreciate patients, especially if the patient are in the stage of chronic progressive or acute on top of chronic RV dysfunction. Simple bedside test auscultation, you can appreciate crepitations. If the patient is having tricuspid regurg, you can appreciate the murmur. ECG can show you the signs of RVH, and X-ray can show you the congested pattern. Echo, and you can appreciate the RV hypertrophy, reduction in TAPSE, and trending high of the BNP, derange LFTs and RFTs. These all will cumulatively tell you that your RV is failing and dysfunction, and you need to do something to optimize this patient. It's not uncommon to see these patients coming for non-cardiac surgery. And here I want to emphasize that my today talk is mainly about RV dysfunction and failure going for non-cardiac surgery, because I feel that in last few years, especially after the COVID, we are seeing a lot of cases of thromboembolic phenomena. We are seeing a lot of cases of interstitial and chronic lung diseases, and they are quite a big burden on our society, and they are now coming and presenting to us in different stages of their disease and coming with different kind of a surgical emergencies, and they are really difficult to handle when it comes to our clinical practice being a perioperative physician. They can come in either in their acute phase, chronic phase, acute on top of chronic phase, and they can come for any surgeries like from emergency surgery, urgent surgery, time sensitive, minimally invasive to a major procedures. And the common acute emergencies which they can come for is intestinal obstruction, obstetric emergencies, trauma, neurosurgery. So we were talking about that you will see a lot of these patients now coming to you for non-cardiac surgeries. And I was giving you one of the example that you have an obstetric patient admitted to with a severe viral pneumonia, and she is in her last trimester, and during her acute disease she has an obstetric emergency for which she has to go for an emergency cesarean section. So you will see these patients with an acute RV dysfunction going for non-cardiac surgery. Similarly, on the other hand, you will see a patient, a traumatic patient with severe lung contusions, and they are having ARDS and they require any time sensitive orthopedic surgery. So you will see a lot of these patients coming to you in your operating room, depending on their disease severity and different kind of surgeries. The main thing here I want to highlight that these patients need to be addressed differently depending on their disease and urgency of the procedures, and you need to identify that whether there is a room of optimization for them or not. So we have to find a way to monitor them. And this monitoring should guide our hemodynamic optimization and further management. So we have to take care of the standard monitorings. On top of that, we need an arterial line to do a regular blood gas analysis and lactate levels. Pulmonary artery catheter, I will talk about pulmonary artery catheter in a bit. And of course, echo, a gold standard to have at least a baseline T, but if you cannot do that, that minimum TDE. The main thing is that you need to understand that if you're having a patient, especially in the phase of acute RV dysfunction or acute on top of chronic RV dysfunction, these patients, you cannot just manage them on the table. You need to optimize them, and the best possible location to optimize them is either HDU or ICU, whatever is available within your unit according to your policy. The main thing is to highlight that you cannot manage them in few hours. You need some time to optimize and manage them. A little bit about pulmonary artery catheter. The pulmonary artery catheter is always debatable, and there were times when I was doing my residency that it was part of ICU and an operating room. But then there was a period of disgrace when pulmonary artery catheter was nowhere, and it has only selective role in few of the cardiac cases. And I feel especially it was because people were more comfortable and more relying on focus. But recently, in last few years, we have seen a re-emergence of pulmonary artery catheters, especially in complex cardiovascular diseases where we require extreme vigilance and precise optimization. So if you use selectively in few cases where you feel that there is a room of hemodynamic vigilance and optimization, then pulmonary artery catheter is really a good way for hemodynamic monitoring and guide you your treatment, effectiveness of your treatment. Here comes the real challenge that whenever we face the patient with RV dysfunction, the real challenge is that there is a very limited studies and data about that. Most of the risk predictors which we always see when we are managing the cardiac patients going for non-cardiac surgery, we look into revised cardiac index, we looked into many risk calculators and guidelines. But unfortunately, most of these guidelines, they don't address RV dysfunction or diseases which is associated for RV diseases. And here I will like to mention this recent guidelines, and I really want to appreciate all of you to go to this guideline and read about it. They have clearly identified that their guidelines unfortunately has a limitation that they don't include severe valvular heart disease, pulmonary hypertension, congenital heart disease. So they already identified that these are the topic which is missed from their guidelines and many of their risk calculators. And they have also identified that the cases with pulmonary hypertension are very complex and it's beyond the scope of the review. So that tells you that even the big bodies like American College of Cardiology and AHA fail to address this problem till now. The other thing what they have highlighted is that these type of patient needs a multidisciplinary approach, and I will talk about it in a bit, that how multidisciplinary approach is a game changer. Here I like to mention the consensus guidelines, which AHA, the American College of Cardiology, plus many of the societies of North America come together and they talked about. There are a few highlights of that guidelines which I like to share with you. They talked about pulmonary hypertension basically, and they have strongly recommended the patient who has pulmonary hypertension and they are on medical treatment, we should continue their treatment and optimize their treatment when they are going for non-cardiac surgery. And they also highlighted that these cases are best to be managed in a specialized with a specialized team, and they need to be managed in a proper intensive or HDU in their perioperative period. Plus, they also have addressed the role of invasive monitoring in these cases, that these are the complex group of patients which require advanced invasive monitoring. They also have highlighted the role of BNP, that it's BNP and the pro BNP is a good marker if you want to see the how what severity of the disease the patient is having and is your treatment effectively working or not. So it's a very good guide to you. They also address the role of pulmonary artery catheter, that in complex cardiovascular disease, especially decompensated heart failure, severe valvular disease, combined shock, and pulmonary hypertension, it's advisable if you mindfully use your pulmonary artery catheter, but they discourage routine use of pulmonary artery catheter. And they also touch upon that, especially the cases of acute severe RV dysfunction, there is a role of a temporary mechanical circulatory support like ECMO if you need to optimize them in a very short time and you need to take them for any urgent or time sensitive surgery. So I want to highlight over here the two concepts that these kind of complex patients, you cannot provide them with physician-centered approach. You need to provide them with a patient-centered approach. You first need to highlight whether these patients are, which stage of their disease. You need to pick them up individually and you need to have a detailed assessment of these patients. Either they are in acute phase, chronic progressive phase, or in acute on top of chronic phase. How their body has adapted to these changes. Are these patients coming for an emergency surgery, time sensitive or elective surgery? How we can optimize these patient risks? What are our according to the patient hemodynamic targets and according to the resources and challenges we are having, how we can manage these patients. Plus, I want to here introduce a concept of multidisciplinary care, that these patients are best managed with when you do a team approach for them, shared decision making. You cannot let one person decide for these patients. It's better for us. I say that we anesthesiologists should play a role of a perioperative physician. We should step up and ask all the team members to come together and decide the best possible treatment plan for this patient, because our aim should not be to just let this patient survive the surgical procedure. Our aim should be to give the good quality life and the best possible survival for this patient. So with that, we talked about that we have some perioperative therapies according to our hemodynamic goals. And you will again listen to the common language whenever we talked about cardiovascular disease, we talk same language like preload, optimize the preload, use the dynamic assessment, manage your afterload. And here we are not talking about SVR, here we are talking about the pulmonary vascular resistance and their determinants of pulmonary vascular resistance is different. So here we are talking about that we have to avoid hypoxia, acidosis, we have to introduce pulmonary vasodilator if there is a room for that. We need to work on contractility of the heart. I'm not here to advertise any of the agent, that which agent is better, but in my 15 years critical care career, I have seen that milrinone has a bit edge on other inotropes. However, I still feel that it's up to the physician. If he knows that what medication he's using and is the medication is giving him the right hemodynamic targets, then this is the best medication for you. And if you are not familiar with any medication, please don't use them for the first time in a most critical patient. So use the medication you are familiar. The only thing is that you need to know that this medication should give you your hemodynamic targets and less possible risk to the patient. And then, of course, you need to maintain the coronary perfusion pressure. Regarding the agent, that what are the right induction agent, again, we are not here to decide that which drug is best. Is etomidate is the best one? Is opioid-based induction is the best one? Here is that you need to identify what are your goals. Whatever agent you're using, if you know your agent well and you know how to use them, you can provide that hemodynamic goals to the patient. If you have an availability of etomidate, use it. If you have an availability of opioid-based induction, do that. But the main aim is that whatever medication you're using, use them to achieve your hemodynamic goals. Plus, you need to work on your ventilation strategies. RV can poorly handle the high ventilatory pressures, poorly handle the high peak, high airway pressures. So be mindful when you're managing your ventilation in these kind of patients. Do serial blood gases. Why? So that you can early pick up hypoxia, hypercarbia, and acidosis. Plus, prevent arrhythmias in these cases. I know that when I was talking about we have to optimize preload, afterload, and contractility, this is not new. We all are hearing this from a very long time. Whenever we talked about cardiac patient, we always talk about the same thing. The main difference here I want to highlight is the difference, the way you manage them. Here is, we need to understand that RV is different from LV. When we are talking about afterload in RV, we are not talking about SVR, we are talking about the PVR. We have to understand that RV is very complex, has almost zero adaptability, and it requires a tailored approach and a multidisciplinary approach. I want to take an opportunity to talk about what are the recent advances when we are managing the RV dysfunction. And the most recent advances is introduction of mechanical support in severe RV dysfunction. And ECMO is one of the rescue therapy that if you're facing the patient with challenging RV dysfunction, ECMO can help you with that. Why I'm talking about ECMO, I know that I'm talking to PSA, but I have come across that NICVD has done many successful ECMO cases, and they are providing the services in other hospitals of Karachi also. So this is not, which is not available in Pakistan, it's available in Karachi, and I think soon it will be available in many centers. So ECMO is one kind of a mechanical heart support, which is not a treatment. It's just a bridge to recovery. And the main indication in RV dysfunction is acute pulmonary embolism, RV infarction, severe ARDS. And how it can help you in optimizing the patient is that there are two cannulas which go in the patient's body. One cannula in the venous system and other, it depends what kind of ECMO, and it's beyond the scope of this lecture, but I just wanted to emphasize that how it works is that one cannula which is there in the body, it strains the blood from the body, and that's how it helps the RV to handle the preload. Plus, when it drains the blood, it's going to the machine, oxygenation will happen, carbon dioxide will be removed, And these two are the main factors which control your pulmonary vascular resistance, and that's how it provides the RV protection. So if you see a patient who is, you don't have any time to optimize or minimum time to optimize, or its condition require some kind of mechanical support, then ECMO in selective cases is a solution for your patients. I like to, what I was talking about in last 30 minutes, I like to sum up in a real scenario, which I had a few months back in my intensive care. I like to share with you, and I want to show that how what I'm talking about in last 30 minutes, I want to summarize in this scenario. So I had a 45 years old male who was otherwise fit and healthy, had a history of fall from 6 meters, and he had an intertrochanteric femur fracture and grade 2 splenic injury. And he was planned for an emergency IM nailing under spinal anesthesia within few hours. And he was a straightforward ASA1E case, and the anesthesia team has planned to do this case under spinal anesthesia. Unfortunately, his case delays for a few hours, I think 12 to 14 hours, and during that time, he developed pulmonary embolism, shortness of breath, tachycardia. Although his hemodynamic was maintained, but he was in a gray zone of submassive and massive PE. And we confirmed this with CT pulmonary angio. There was leak of troponin, leak of BNP, and we were in a clinical dilemma where a simple ASA1E case was converted into the high-risk ASA4 case. The surgery was postponed, the emergency surgery was postponed to the time-sensitive duration. So what happened is that we had a young patient who is a sole bread earner of his family. He was really upset and anxious, first of all, because of his own disease. Plus, he was worried that he cannot afford all the treatment. And his other worry was that if he end up in any of the long-term permanent damage, then he cannot support his family. So there is a lot of not only the physician dilemmas, but we have a lot of problems with the patient side also. We discussed the case with the hematology, and hematology advised that because of his splenic laceration and acute insult, he had some lung contusion also, we cannot offer him TPA. And the surgeon said that I cannot delay the surgery more than 72 hours because there is a risk of disability is very, very high. So I was being an intensivist, was thinking that if I will leave him like this only with heparin infusion, he will end up in chronic pulmonary hypertension, and at last his LRV will fail. So the point was not that let's delay his surgery for a few hours, stabilize, and then take him. That was not an answer. The answer was that we need to give him the best possible outcome so that he can support his family and live a healthy life. So we approached all the teams together and discussed, and we made a shared decision making to give the best possible option for this patient. I had a discussion with the cardiologist and the surgeons, and we decided that let's first fix his pulmonary embolism. So we said, okay, there is a lot of thrombus load on him, so we need to do something to avoid his pulmonary hypertension. So the cardiologist said that I can do a mechanical thrombectomy for him. And the plan B, if it's not work or some challenges will occur, we will give him catheter-directed thrombolysis. That was the plan B. Despite that, we were in Kuwait and we had a lot of resources, but it happened last month when we were in the war zone. I don't want to discuss more about it, but unfortunately, because of the airspace closure, we didn't get the supply of our devices. And we were back into the resource limited situation where we cannot offer him mechanical thrombectomy. And we didn't have a proper device to give him the catheter directed thrombolysis. So we decided that we give him local TPA through pulmonary artery catheter. So we use pulmonary artery catheter for our hemodynamic monitoring and for delivering the TPA. We manage him in ICU with continuous monitoring, serial ECG, troponin, continued TPA for next 48 hours, and we have seen him improving in his symptoms in 48 hours. And in less than 72 hours, he was in operating room under general anesthesia, did his procedure, stayed 24 hours post-operated and discharged home. So why I shared this case, this is a case, a perfect case to show that how a simple case can convert into a difficult and a challenging case, which require a patient-centered and the multidisciplinary approach. So this is one of the examples for that. And with this, I would like to end my presentation. I will really like to encourage all of you to read this recent guidelines on perioperative management, where they have rightly identified a lot of limitations, and they have clearly identified the selective roles of the pulmonary artery catheter. Please, if you have time, please look into that. And I'm open to answer any questions.
Thank you, Dr. Beena. Very nicely explained the management of patient with RV dysfunction and the use of advanced hemodynamic monitoring. I will request all the participants, if they have any question, please write down in the chat box. Meanwhile, we have Dr. Faraz Shafiq, Dr. Soleh Khaskheli, and Dr. Khalid Shah with us. I will request, first of all, I will request Dr. Faraz to please unmute yourself, and we want to hear from you. Dr. Faraz. Dr. Faraz, are you there?
Yes, I am here. So what you were saying, sorry, I got disconnected just by the end of the presentation. So,
Yeah.
so I don't have any question. But I just have a comment. So, Dr. Beena, thanks for such a wonderful presentation. And especially, I'm really impressed by, your presentation in terms of, so every thoughts which you have, explored or which you have delivered tells us about your wonderful experience you have got in the field of critical care and in the field of, perioperative anesthesia. So I'm really thankful to you. Your presentation was wonderful.
Thank you so much.
Thank you,
It's
Dr.
so nice to hear from my seniors and my colleagues, the old colleagues. Thank you so much.
Dr. Soleh, can you hear me? Are you there? I think Dr. Soleh is not with us. Okay, he's there. Dr. Soleh, can you hear me? Dr. Khalid, are you there?
Yes, I'm here.
Yeah. Dr. Khalid, if you have any additional comment, please, if you can share your experience regarding the RV dysfunction.
Well, to tell you the truth, since I've been in novice, I've had this a huge amount of stress related to right heart failure compared to the left heart, because dealing with the right heart failure can be quite tricky and very, very difficult. We all deal with the left ventricular failure so easily. And an amazing presentation covering all the relevant topics, causes, indications, medications, everything. Very nicely, Dr. Yousuf. I must say, I have to say this in Urdu, आपने दरिया को कूजे में बंद किया है. So I think it was really, really amazing. Thank you so very much. And I would like to encourage everybody here to read upon the topic and try and include this, whatever we have learned from the presentation today in your daily practice. And I hope that you will provide better care for your patients. Thank you.
Thank you, Dr. Khalid. Okay, meanwhile, we have a question asked by Dr. Muhammad Ahmed Khakwani. He's asking any specific guidelines you can share for RV failure in post-op TOF total correction patient, where we can find if there is any guideline which could help us.
So I think I haven't touched about the cardiac disease and the post-cardiac surgery, because I feel this was not the most important subject, because it needs a different presentation for that. But if you go into the detail of American College of Cardiology and the AHA guidelines, they talk a lot about the cardiac surgery. and the post-cardiac surgery repair, but sorry, I have no experience in that, and I haven't included that in my talk. So my
So
apologies for this.
yeah, there is another question. I think we have touched this question already. You have touched this question. Is there any place of PA catheter in modern anesthesia in the presence of PICO, LITCO, etc., where we can use if we have to PA catheter? In which cases?
Okay, very good. I think this is one of a very good questions. I think the pulmonary artery catheter, as I talk about, it's always in the debates. Some people like to use it, some people don't like to use it. Some people like to rely more on focus, some people like to rely more on non-invasive PICO, LITCO. So PICO and LITCO has their own positives and lot of limitations. And one of the limitations is that it's subjects to, it's a non-invasive way and a computerized way to tell you. So there is many limitation that they cannot give you the real-time picture what's going on in your right side and the left side of the heart. So I feel that if better than LITCO and PICO, you better rely on your echo. And if you have a chance and you want to see and you want to be very vigilant in your management, especially with a complex cardiovascular disease, then selectively, only in selective cases, uh, I appreciate that you should use pulmonary artery catheter, and it's supported by all the recent data and the guidelines that if you use them in a right way, then it can provide you with a lot of valuable data and it can guide you intraoperative and in your post-operative period. But LITCO and PICO have a lot of limitations.
Thank you. So, Dr. Jahazev, are you there? If you're hearing me, please unmute yourself and please share your experience in your setup in UK.
Assalamu alaikum.
Wamslam.
Well, first of all, thank you very much. It was a very nice presentation in Beena. It was good to see you after so long.
Oh, thank you.
Very important topic, are we? Which is usually we don't see
Sorry,
very usually in
Dr.
our
Jahazev,
clinical.
just interrupting you. Unfortunately, we can't see you.
Oh,
Yes, we have to see you, Jahaziv.
wait a second, let me turn on the camera if I may.
Okay, so I was on a lighter mode. You can continue, please.
No, that's fine. No problem. I think RV is a very important organ, and we came across RV failure multiple times during our critical care. I've worked in cardiac ITU in Saudi Arabia, so we were very much familiar with these post-op RV failure, and different strategies were used for acute RV failure, and which I think there was a disconnection of the presentation for a little while, so I missed that part. So I'm not sure whether if Beena have mentioned anything about the nitrous oxide in the acute RV management. That is something which we have used a lot in the post-cardiac surgical unit. So that's the important thing. People need to know about that one. But I think, Beena, you covered most of the topic about the RV, and I must really appreciate, as a you're coordinated very well, and Beena, you presented very well. Thank you.
Yeah, so there is, you rightly identified that there is a role of inhaled pulmonary vasodilator, including nitric oxide, and I have used a lot, not only in the cardiac surgery, but even in my ICU a lot, and I've seen a lot of promising outcome with that. So yes, it has a role. Not only that, but inhaled prostacyclin also has a very promising role in reducing the pulmonary vascular resistance, but only in acute or cases. I haven't seen much benefit in the chronic or chronic progressive disease cases.
Thank you, Dr. Meena. I'm sure in our part of the this world, many of the patient pass away because of the not timely managed and identified RV failure. So, what you will suggest us in LMIC countries? What should we do if a patient is having underlying RV disease with limited resources? What at least at the minimum that we should
I think the main thing where I want to highlight here is that to change our mindset, even if you ask your cardiology colleague that I need an evaluation, this patient is having some cardiac symptom, this patient is having dyspnea, whenever they echo, they only comment only on the left side. Unless you ask them that I want a comment on the right side, nobody like to comment on the right side. So that tells you that right side is always under recognized and always under seen. So we need to build an awareness that it's okay to even say the negative findings. RV is okay. RV is working well. So this is the main thing. So if we start looking actively and consciously towards the RV, then you start picking up the disease. I don't think so that it's a matter of underdeveloped countries or resource limited country. It's the mindset which we need to change.
Thank you. So with this, we come to the concluding remarks. I will request Dr. Shahid Rasool Dar, if he's hearing me. He's from the Ghurki Trust Hospital, and they are doing a wonderful job over there. Please, if you could give Dr. Shahid, if you're hearing me, unmute yourself and give the concluding remarks.
Thank you, Dr. Azhar. Very good presentation. I also noticed that we really missed the right heart failure a lot, and our PG trainees are very much reluctant or very poor in managing such kind of cases. In our setup, a lot of these cases are not most frequently seen, but they are usually underdiagnosed or undiagnosed. And very nice presentation from by the doctor, Yousuf, and it is very nice to heard. And I think they cover most of the topic. Thank you, Dr. Azhar.
Um, Thank you, Dr. Shahid. So there is a last question asked by Dr. Tabish Hussain. Um, uh, he mentioned here is a case, and after that he asked about the RV systolic versus diastolic dysfunction. Any clinical significance?
So basically, when we talk about systolic and diastolic functions, we usually talk about that this is the main thing which is a characteristic of the LV, because that's how the LV, we always say that LV is the one which is meant to handle the pressure. RV is only meant to handle the volume. So when we talk about limitation in the diastolic, that means we are talking about the compliance of the RV. So of course, it will affect the overall volume handling and overall the preload handling of the right ventricle. But when we specifically talked about systolic failure and a diastolic failure, that means that you're again looking to the left side heart, not the right side of the heart.
I'm sure you got the answer. Uh, Thank you, Dr. Beena. Thanks for sparing your precious time. Hopefully, we'll hear you in some other meeting, in some other forum.
Inshallah. And I really want to thank PSA for giving me this opportunity and to get to connect to my people of Pakistan. Thank you so much for giving me this
Yeah.
opportunity.
And we can hear this talk on the PSA YouTube channel as well after 2 or 3 weeks. It will be uploaded on that channel as well. Thank you, Dr. Beena, at the end again. Thank you. Allah Hafiz.
Allah Hafiz.
Yeah.
end the